Neonatal abstinence syndrome and neonatal opiate withdrawal syndrome are usually managed by the pediatrician, and the pediatricians are the doctors that take care of the babies after they are born. However, as an OBGYN, it's important that we have these conversations with patients if there is substance use, either illegal drug use or medication-assisted therapy for like opiate use disorder, since this will affect their baby after they are born. So neonatal abstinence syndrome is when after babies are born, if they have withdrawal symptoms from either a medication that the patient was on when they were pregnant, and just kind of an overarching theme. And then neonatal opiate withdrawal syndrome is specific to opiates. So if patients are using either recreational drugs or if they're using a medication that it has an opiate in it, it can also cause the babies to withdraw with that after they are born.
Neonatal abstinence syndrome is a big umbrella of symptoms and signs that demonstrate babies who were exposed to different medications or substances intrautero. It can happen as tremors, vomiting, or more severe ones like feeding difficulties or weight loss in babies. Neonatal opioid syndrome is part of this big umbrella of NAS, but it's more specific. It happens when babies are exposed to opioids, such as fentanyl, such as oxycodone, and all the family of opioids while the baby was in the womb. The symptoms are more specific and sometimes it could be life-threatening as well.
Specifically for neonatal opiate withdrawal syndrome, there's been some shift in the way that we manage these situations. There is a new protocol that we have at Stanford that we've been utilizing called Eat, Sleep, and Console. And this is to help patients and their family members help track and document how the baby is doing after they are born. They actually focus on, is the baby sleeping for more than 10 minutes? Do they wake up frequently? Do they have more time or difficulty consoling? And then in teaching and advocating for parents and caregivers and educating them on how to do more skin-to-skin contact, help with breastfeeding, and then actually have like a low stimulation environment, so dimming the lights, making sure the TV is off. That is a newer care model that's been implemented at Stanford that we tried to have with patients where their babies are having neonatal opiate withdrawal syndrome. The other thing that can be useful is like a medication management, so giving patients or babies opiates to help with the withdrawal that they're having. There's data to show, or there's science and studies to show that patients that use Eat, Sleep, and Console, their babies go home earlier, 8 days compared to 15 days with more of like the stronger medication management, as well as there's less medication that is required. And this is a really important topic because it takes a whole care team to help patients or babies when they are struggling with neonatal abstinence withdrawal syndrome, that sometimes medication is needed and sometimes the more skin-to-skin contact and breastfeeding and low stimulation environments are needed.
When we are facing the possibility of a baby being born with a probably neonatal abstinence syndrome or neonatal opioid syndrome, the care after birth is the same as all, but we have a special observation and monitoring period to make sure that the abstinence syndrome that the patient is going to start presenting is well taken care of. We have to work as a team with the parent, nursing, and doctor and try to identify if there are any signs of symptoms of a severe neonatal abstinence.
Early prenatal care, we usually like to start to see patients for their prenatal care when they're anywhere from like 8 to 12 weeks of pregnancy. And one of the biggest things that we do at like the first OB visit is actually get a full history and see if patients have any medical issues that need to get taken care of, whether it's high blood pressure, diabetes, do they have anxiety or depression, are they struggling with substance use? And when we see patients for the first time, it's important that we take a full history and see if they actually need other resources as well. Do they need help getting to their clinic visits? Are they worried about taking care of the baby after they're born? Are they worried about car seats? Are they worried about diapers? And it's a good chance for us to be able to meet the patient really early on in their pregnancy to see what type of care that they need, not only for their medical care, but also for the care of the baby after the baby is born. The other important thing is that seeing patients kind of like once a month, sometimes a little bit more frequently than that, sometimes a little bit less frequently than that is good because we can check in with the patients as their life changes over the span of a 9 to 10 month pregnancy, and making sure that they have the resources that they need to come to their visits and also take care of their baby after their baby is born.
It is important, the prenatal care and the screening, because it's gonna give us information of the well-being of the baby. We can anticipate problems, we can anticipate issues when the baby is being born. If we can detect maybe any anatomical malformation, or maybe mom is sick, that is gonna complicate the delivery of the baby, and the post-prenatal care of the mother is important for us to detect and make up very organized after the birth.
When it comes to kind of medication or recreational drug use substances in pregnancy, breaking it down. So first, caffeine. So whether caffeine's in soda or coffee, having a little bit of caffeine is okay. We usually say about a cup of coffee a day is okay, or about 200 to 300 milligrams of caffeine. In patients that use more caffeine than that, there's a risk for some behavioral issues with the kid after they're born, and then very rarely, maybe the kiddo might be a little bit small when it's born. When it comes to medications that the patients are on, whether it's for diabetes or high blood pressure or mental health medications for anxiety or depression, those are all very tailored to the specific patient, what medication they are on. So that's why it's important for patients to see us OB/GYN so we can see if they need any special follow-up care, if they need any special testing during their pregnancy. When it comes to more recreational or illegal substances, so fentanyl, heroin, meth, medications that patients are taking that aren't prescribed to them, there are risks usually of the kiddos being small when they're born, sometimes the baby coming early, sometimes getting really bad high blood pressure, and then potentially an increased risk for a stillbirth as well. But it kind of depends on what the patient is using and then what other medical issues that they have as well.
The effects of different substances depend on what is the substance. For example, caffeine in low to moderate amounts is thought to be not harmful for the baby, but in severe or very high quantities on caffeine is being associated with early term or early deliveries. The other substances, for example, opioids, can affect the babies can have neonatal abstinence syndrome, and also have been studies that are related with that low attention in kids or learning difficulties as well. So it depends on that substance and the amount or for how long is the baby being exposed to that medication.
One of the big things that Sanford has that's a great resource for our patients is that we actually have assistance for transportation to come to clinic visits. So we have someone that is dedicated to going and actually picking patients up to go to their clinic visits and bring them. And we can actually coordinate rides even if patients don't have cell phones, if they don't have internet, we can schedule all of that beforehand, which is a great opportunity for patients to be able to come and be seen. The other thing is that we're really pushing on assessing what patients need to be able to come to their clinic visits and then to feel safe and comfortable taking care of their babies once they're at home. When it comes to substance use disorder, unfortunately, it's very common in pregnancy. There are, newer medications and a shift in the practice of care when it comes to mostly opiate use disorder. So if patients are using fentanyl or heroin, misusing prescription medications, we have resources here at Sanford to help patients whether to get started on methadone or medication-assisted therapy, whether it's Suboxone or Subutex, and we have providers at our clinic that are comfortable assisting with starting that medication as well as getting patients resources to be able to follow up and have a long-term management plan. It is a very scary thing to disclose to providers and people in healthcare, and our goal is to come from this not from a judgmental standpoint, but to come at it from a perspective where we're here to help, and we want to help you any way that you want to the best of our abilities, as well as also make sure that we have the resources available to help you and meet you where you are at.
I think the most important thing is outreach and education and helping mothers to be present at the prenatal care. The most important thing is the process of screening these babies, these mothers during the prenatal care, give education during that visit, and providing a good, comfortable environment when the baby and the mother are present in the hospital.
I just encourage people to, if we are not asking questions and you are worried about something, to tell us. You know, we do our best to try and answer questions, and maybe we worded a question incorrectly or in a way that was confusing, so just please let us know if there isn't something that we addressed. It's on us as providers to ask the right questions. However, we are not perfect. If there's something that you aren't comfortable with or you want more clarification, please ask, and either we will answer it to the best of our ability or find the right people who can answer that question.
There is an outreach program done by Beltrami County that tried to gather mothers and try to encourage them to be present during the prenatal visits.
The first thing that I want to speak to is that pregnancy is not a cure for addiction. Women that are carrying a baby or women that are pregnant if they are in that addiction cycle, it is really hard for them to get out of that alone. They need help, they need supports. And I feel like in Bemidji we have a really great network of people who work with pregnant women with SUD. And if someone is in chronic use, it is very important for them to reach out to their providers, reach out to the county, reach out to an SUD agency of some sort. So there are multiple resources available to someone who is struggling with chronic use, especially during pregnancy. They can go into a clinic and get medication-assisted treatment. They can get into treatment on an outpatient level. They can reach out to other sober supports within the community. They can get an assessment completed, which would tell them, you know, what their need level might be. The biggest thing is that they're not alone, and it can be a very isolating kind of a situation for these women. And it can feel a very lonely sort of a thing because they don't want child protection to take their child away. So that's a lot of times why they stay hidden. And we want to make sure that the message gets out to the public and to the community at large that there is support available. If they are proactive in receiving services and receiving help, then the likelihood of them being able to take baby home from the hospital is much greater.
One important thing is that we don't have to stigmatize the mothers who are undergoing this hard pathway of substance abuse. We have to stop the stigmatization and try to help as much as possible the mother and the baby to be comfortable and being open and try to disclose as much as possible the substances this mother or this baby are exposed to. In that way, we can elaborate appropriate plan and an appropriate treatment for mother and baby. Neonatal abstinence syndrome is a big umbrella that covers most of substance-related conditions that a baby is exposed. The neonatal opioid syndrome is part of this neonatal abstinence syndrome complex that is very well identified when babies are exposed to opioids. The management is different and the time frame is different for how long this baby can present those withdrawal symptoms. The care is similar to all the babies that are born, but we have two main treatment levels. One is the no medications and other is with medications. The treatment that we do with no medication is when babies are having mild withdrawal symptoms, and we tend to give them, the most important thing with this is that the baby has to stay as much as possible with the baby. We try to give them comfort, adequate nutrition, tend to leave them an easy and non-stimulant environment, so it decreases the amount of interruptions or it decreases the amount of stress to the baby. If the baby is already showing signs of moderate to severe withdrawal symptoms, then we may need to consider starting some medication for that, such as buprenorphine, morphine, clonidine, and we always make the decision with the parent and the nurse involved.
Well, Pregnancy is a complicated thing. The earlier that they get in to go through screenings with prenatal care, the earlier that they can provide interventions if those interventions are necessary. So early care is always recommended, and even if a woman is later in pregnancy, I don't want them to think that they can't go in for prenatal care because they're struggling with substance use. There's help available, and it's super important to assess that pregnancy all the way through. And if they're not attending those appointments, then that is not happening. Substance use at any level during pregnancy can be harmful to both mom and baby. There are certain categories of drugs, though, that are really scary, opiates being one of them. So if a person is using fentanyl and she's pregnant, everything that she takes, baby takes. And when you're getting high and then going through the lows, baby is also experiencing that. And there can be all kinds of complications that can arise, including fetal death with opioid withdrawal. With methamphetamine, with any of the substances, it can limit fetal growth, it can induce preterm labor. There's a lot of complications that can arise, so we want them to get the supports in place earlier as opposed to later. The biggest thing with connecting people is I think our communities and our agencies need to do a good job of collaborating between themselves, because if we are all working with the same population, we all need to be aware of the resources that are out here. And I think in Bemidji we've worked really hard to those connections and to know who provides which service. So if a client, for instance, connects with me, I know the people in the LADC world who I can connect them with for for an assessment or for treatment, and the people at Sanford and the programs that are there, and tribal programs. And I can connect people with the services based on their individual needs. And that's one of the beauties of living in this community and working in this community, is that we have a great collaboration between agencies.